patient complains of fasciculations in the hands, face and legs, how do you differentiate between benign fasciculation MND? Very simply, it's in the name, right? Motor neuron disease. So you can look at the rest of your motor exam. So you're looking at your lower motor neuron signs and your uppermost neuron signs. Are there signs of flaccid muscles? Are there hypertonic muscles? Are there a loss of reflexes or hyperreflexia? Whereas in benign fasciculations, everything's good. Everything is absolutely fine. You've just got those annoying fasciculations. And is pain part of MND? No. However, because the patient is losing motor, they're going to have a change in the control of movement, balance and posture. So they absolutely have the right to have a pain presentation. It's just that the motor neuron disease itself is not a source of pain. But as they start to lose stability and mobility, they may well have other forms of pain. Right, round 5, we're on to the last round, guys. So a patient presents with pain behind the right ear. You manipulate his neck and 2 days later he wakes with a face like this. What's the most likely diagnosis? So a patient presents with pain behind the ear. You manipulate his neck and 2 days later he wakes with a face like this. What's the most likely diagnosis? And I'm of course referring to his facial paralysis and not his ugly mug. So what would cause that ipsilateral facial paralysis? Okay, question number 2. Oops, there's the answer right there. So let's go through as we find. Bell's palsy or facial nerve palsy. So when we have complete ipsilateral facial loss, it means we hit the lower motor neuron, and Bell's palsy is going to be the most common one, also known as facial nerve palsy. So basically, as it's passing through the canal behind the ear, it's going to get compressed. We think maybe due to inflammation related to, possibly related to an infection, like a viral infection or something like that. But they often present with pain behind the ear for 1 to 2 days before the paralysis starts. Now, when it comes to recovery, incomplete paralysis by the end of the first week is a better sign for recovery. The average person will take about 6 to 8 weeks to have a good recovery with that one. About 2 to 6 weeks. 80% of people have about in the first 2 to 6 weeks will have a pretty good recovery. If recovery hasn't started after 12 weeks, then that's a really bad sign. So if after 12 weeks they are still looking pretty similar, then unfortunately there's a good chance it's not going to get much better. Diabetes is a risk factor and hypertension is a risk factor. So again, if you have a patient come into your clinic and they say, oh, I've got pain right C1, I just need to adjust that, and you know they're diabetic, or you take their blood pressure and you find they're up, I would probably wait a couple of days before you do that adjustment. Question number 2. Now, my face, unfortunately, is a little bit in front of this person. Let's see how much you can see there. Not enough. So let's just drag me out of the way and let's run that video again. So what type of gait is that? So let's go straight into the answer. Hopefully you can see there that is a pretty obvious drop foot. That's a terrible drop foot too, right? Poor person. So drop foot, you could also call it a neuropathic gait. That'd be a good name for it. So you can see in that they have normal hip flexion. They're not circumducting the gait. They're not circumducting the leg, sorry. So there's no real sign of spasticity in that leg. It's not the leg is locked out and they having to swing the leg round to not trip over the floor. It's just that leg is that dorsiflexion is just completely absent, right? They cannot lift that foot. Okay. A patient presents in severe pain, often screaming out with brief bursts of burning pain. Her cardiovascular exam and abdominal exam are normal. What pain syndrome might cause this? So a patient presents with severe pain, often screaming out with brief bursts of burning pain. Her cardiovascular exam and abdominal exam are normal. What pain syndrome might cause this? So hopefully you can see the difference between the 2 feet, that extremely large, red, swollen foot. What might cause that? So the answer is complex regional pain syndrome. It used to be called reflex sympathetic dystrophy or causalgia. So I've seen a few cases of this and it is horrific. Patients literally will be sitting on your bench doing nothing at all, and they will just start screaming, and there's nothing you can do to help them with it at that moment in time. So when we talk about chronic pain and pain sensitization and all that kind of stuff, complex regional pain syndrome is kind of the mothership. A horrible condition. Okay, round, have we missed a round? Nope, sorry, round 4. What sign is this? So let's play that for you one more time. So hopefully that's fairly easy for you. That's ankle clonus. So it's uppermost neuron sign. So what we have is uppermost neuron damage. This is actually a patient who has spinal cord, it's a very severe spinal cord injury. And so as we stretch the foot and we get that muscle stretch reflex, it's bouncing back, right? And it's going to sustain itself. As patients start to get better, because they really can, you'll start to see that they'll start to get more descending control of that muscle stretch reflex. And so in the beginning, whereas it might pulse endlessly, eventually it might start to only do it for 5 seconds, maybe only 2 seconds. The power will go down, so maybe rather than bam, 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 it might start to slow down, so it's bop, 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 or it's weaker. Or if they really engage with it, they can bring it to a halt. Okay. Name the cranial nerve weakness and which side is affected. So name the cranial nerve weakness and which side is affected. So if you're looking at that soft palate, hopefully you can see there's a problem there. What would cause that problem and which side is affected? So that is a cranial nerve 10 lesion, the vagus nerve, and the problem is on the left. So what you're seeing is the left side is paretic, it's where it's dropped down. The right side is strong, so it's pulling the uvula up towards that side. Guys, that's it. Thank you very much. I hope that was worth doing, and I hope you did well on your scores. That hopefully was arranged in a fairly logical way, that we had peripheral nerves, and we had central cord, and we had central nervous system, we had headaches. So if you found that there was one round that you really struggled with, I highly recommend you go and focus on that, go and study it. I'm going to be producing more information on these different topics in the future, so keep your eyes peeled. But thank you very much for playing. If you have any questions or you want to know more about why the answers were the way they were, feel free to get in touch.